A very good afternoon to all of you. Thank you for coming. Thank you so much, Sandeep, for inviting me. It's indeed a pleasure to be here again in Calcutta. So I'll be talking on endoscopic management of gastroparesis, evaluation and treatment. So as we approach the topic of gastroparesis, let me go through some of the basics. What is the normal gastric emptying and mixing? So just going back to the basics in medical school, when the patient ingests food, the food reaches the stomach, and the first thing that occurs is fundic relaxation. And this is gastric accommodation, which allows the food to come inside the stomach. Then it moves towards the distal part of the gastric body, where there are antral contractions against a closed pylorus, resulting in trituration. That's the food is broken down into smaller pieces. Subsequently, the pylorus relaxes, and the antral motility results in gastric emptying. So now this is a fairly complex process involving various muscles, and therefore any disease related to this is hard to treat. So normal gastric emptying, if you look at the curves on the bottom left, is the water. So there is rapid emptying and then it slows down. And then as you see the middle curve, which is the green colored curve, it's a fairly linear curve, which is for high calorie liquids. And then on the right in black is the curve for high fat solid meals. So when you look at solid high fat meals, there's slow emptying initially and then it sort of gradually empties. The normal gastric emptying function is regulated by the interstitial cells of Cajal, which are the pacemaker cells in the stomach. So similar to the heart, there are pacemaker cells in the stomach. The excitatory and inhibitory signals reach these cells from the enteric neuron with the synapses as shown on the top right figure. Mediation of the impulses occurs through nitrous oxide or acetylcholine. And what you see is parasympathetic impulses result in contraction of the gastric muscles and relaxation of the pylorus. And sympathetic muscles result in relaxation of the gastric muscles and closure of the pylorus. So quite the opposite effects. So what happens in diabetic gastroparesis are several dysfunctions and several pathological changes. So one, there is neuronic dysfunction, muscle dysfunction, immunological dysfunction. And a combination of all this ultimately leads to impaired accommodation, antral hypomotility, and pyloric dysfunction. So these are exact mechanisms which are functioning to empty the stomach. And in gastroparesis, all these are impacted. So let's focus a little bit on pyloric dysfunction. This is something that was described in 1986 in a series of patients initially. And they first felt this was from autonomic neuropathy. And now it's discovered that it's from the loss of interstitial cells of Cajal and less nitric oxide, resulting in what we call as pylorospasm, preventing the emptying of foods from stomach into the duodenum. Now, most recently, what we have are new tools. This is called EndoFlip. Now, EndoFlip is like manometry catheter with a balloon. So the EndoFlip has the ability to measure pressures, and they create these beautiful 3D images on the top and the bottom right of the screen. So this study was performed in many healthy and gastroparetic individuals, and what you see is the pyloric pressures are not different between the three groups. But the pyloric compliance, that's the distensibility of the pylorus, was lower in those who had gastroparesis or had esophagectomy. So just highlighting in the bottom right figure, the pylorus basically just doesn't seem to open. So that's what we call as pylorospasm, and this is proven with the new technology that is available, the EndoFlip. Unfortunately, not yet in India, but I'm sure it's coming soon. So if you look at symptoms of gastroparesis, patients have nausea, vomiting, postprandial fullness, and bloating. And as most of you gastroenterologists would be aware, this is very similar to dyspepsia, but some classic telltale signs of gastroparesis would be vomiting of old food. So I do ask my patients oftentimes, do they vomit something in the morning what they ate last night? Now if that's the case, that is concerning that the food is really not emptying into the small bowel. However, that's not a telltale sign, and majority of the patients will not report that. So you'll really need to investigate these patients to confirm if it's gastroparesis. Gastroparesis Cardinal Symptom Index score. It's good to be familiar with this score because this is used in research studies, and as we are evaluating the data, this is what it's comprised of. It looks at 9 different variables scored from 0 to 5, and a composite score is formed. Now remember, before evaluating for gastroparesis, it's very important that you ensure there's no structural abnormality, because that's a functional problem. Just like achalasia, you want to do an endoscopy before, making sure there's no cancer causing the obstruction. All right, so as we move forward into evaluation, I spent a lot of time, about 3 years, with some of the experts in the field of gastroparesis, Michael Camilleri, Dr. Adil Barucha at the Mayo Clinic, and they have literally published half the world's data on gastroparesis. So I had a pleasure of working with them and learning all about gastroparesis with these individuals. So as we evaluate these patients, the gold standard is gastric emptying scintigraphy. So this is a nuclear medicine scan which involves using a radioactive isotope which is mixed with food and is ingested, and then serial images are obtained over the next 4 hours. Now I'll delve a little more in this because this is primarily the way in India you're going to diagnose gastroparesis, and I'm aware that availability of this is limited and the quality can be patchy, and I think it's very important that you understand, if you are planning to do gastric poems and such procedures, then you need to understand how to diagnose gastroparesis and whether it's done correctly or not. So various factors can actually impact gastric emptying. The way it's tested, posture, food composition and preparation, the duration of measurements, use of medications. So I'll just go over these factors in a short time. So it's just important, the standardization of how the procedure is done is important, and believe me, a lot of labs out there are not doing it correctly. So if you look at the effect of posture, this is an old study, 8 subjects underwent gastric emptying study in different postures, lying down, standing, supine, and what they found was there was a greater than 50% variation. So people who are lying down had slow gastric emptying versus the people who are standing and walking. The food plus tracer, it's important that the tracer is just not sprinkled on the food, and this may happen in the inadequately performing centers. So it has to mix and has to be cooked with the food, and in the Western world they use egg. In India there is a vegetarian option, and ultimately the isotope has to be with the food in gastric conditions, and that's important. In terms of the duration, if you look at the gastric emptying in patients who are healthy versus gastroparesis. Now what you can see is at 1 hour, gastroparesis or healthy individuals, the gastric emptying is similar, 91, 93%. At 2 hours, again, not very different, 66 and 77. At 3 hours, you start seeing a difference, 40% versus 70%. And at 4 hours, there's a distinct difference. So if you are looking at a report which is 2 hours, do not believe in it, because you need a 4-hour report, at least 3 hours, if not 4 hours. Several medicines affect gastric emptying, including the prokinetics, so they have to be stopped for 72 hours. Opioids, calcium channel blockers, beta blockers, and a host of medicines can impact gastric emptying. So these have to be stopped for 72 hours before you evaluate and send these patients. Can be a bit of a challenge sometimes to ask patients to stop. And if you look at the values, upper limit of normal retention is 30% at 3 hours and 10% at 4 hours. If there's more remaining, that's suggestive of gastroparesis. So my advice is to call your diagnostic center and check exactly how they're doing it before you start doing these procedures based on their reports. What's available in the West is isotope breath test, and I'm going to briefly talk about this. This is a stable non-radioactive isotope 13C, and basically it's absorbed after gastric emptying, transported to the liver, where hepatic metabolism leads to exhalation of 13 carbon dioxide, and then you measure the ratios between 13 and 12, and ultimately this you can create a curve which predicts gastric emptying. The studies have shown that it has excellent correlation with the gastric emptying gold standard scintigraphy test. And just move forward. There's something called wireless motility capsule available in the West, but not available here, and it gives tracings which then imply the emptying of this capsule from stomach into the small bowel. Capsule exists in the stomach, not in association with the meal, so that's a problem. It's not a very physiologic way of measurement. What we have available in India is what we call as electrogastrography. It's like ECG but of the stomach. and they measure all these waves. Studies have not shown any difference between gastroparesis and dyspepsia in the sort of pattern of waves. So it's not very helpful. There's one study that they performed in pyloric dilation was performed in these patients with gastroparesis, and they classified them into hypernormal and normal subjects. And people who are hypernormal responded well to treatment versus the normal GMA activity ones. So this is what there's very no data literally, and this is what the company proposes, that hypernormal ones are responsive to pyloric therapy, but there's no strong evidence. So how about management? It involves dietary intervention with small meals, multiple meals throughout the day, low fat, low indigestible fibers, and liquids. So no fatty foods in these patients. I'm going to skip in the interest of time to the more relevant endoscopic options for treatment. Just to note, prokinetics have side effects and would not recommend keeping them long term. And I'm going to move forward to just show you a video of a patient who had an adverse effect from levosulfide. I'm sure all of you use this all the time. So this is a patient who has a permanent neurological damage, which is retrocollis. It's an extrapyramidal side effect from levosulfide. So therefore, we don't want to use these in the long run. So therefore, endoscopic options are available now. These include Botox injection, pyloric balloon dilation, and gastric poem. So let's talk about gastric poem. This is sort of an illustration of a case where we tunnel in, and I think there is a case live demonstration, so I'm not going to play the video for too long. But this is tunneling through the antrum, and you basically, this is a tunnel which is created across the pylorus, and then here we are doing a myotomy of the pyloric muscle, which is in pylorus spasm. You see here, and then ultimately we'll come out and close the entry site with multiple clips. So I'm not going to get into that. So this is my combined experience in the West and in India, about 13 patients. 12 out of 13 we achieved technical success, 8 had significant clinical improvement, and 3 reported no change. So if you look at evidence of gastroparesis, meta-analysis of 272 patients, 84% clinical response rate. In long-term follow-up, after 3 years, 81% response rates in this study. Most recently, there's a randomized controlled trial comparing GPOM versus a sham procedure in severe gastroparesis patients. There was no difference at baseline, 21 patients in the GPOM arm and 20 in the sham arm. There was significant reduction in the GCSI score with GPOMs, and then the sham arm, which is in blue, when they were then assigned to GPOM, there was an improvement in scores, thus suggesting that GPOM is effective in a randomized controlled high quality study. Clinical response is seen in all the types with nausea, vomiting, fullness, and bloating, and distensibility as measured in the endoflip improved after successful pyloromyotomy. So just suggesting that the pathophysiologic problem has been addressed. So what are the predictors of success following GPOM? Because this has been the main problem. Patients undergo a major invasive procedure, and we don't know which ones will respond and which ones will not. So endoflip can be very helpful. This is a series of patients, 17 patients. 11 had improvement in symptoms and 6 did not. What they found was higher pre-myotomy pressure and lower distensibility index, which means the pylorus was not opening well. And those were the patients who were responding to GPOM versus the ones who did not. This is a recent published study in gut, 5 centers, 80 patients. 56% had response, and they looked at various factors. Baseline GCSI score more than 2.6, fullness, bloating, gastric retention more than 20% at 4 hours. So they found ultimately with multivariate analysis, high GCSI score and gastric retention more than 20% were predictive of success. Another study looking at this using a clinical score without the endoflip, which is what we can do here in India, is the nausea scale was lower in those who were successful, and the bloating score was higher. So what they did was created this scale with low nausea subscore, high satiety and bloating, high gastric retention, and with this they could predict which patients will successfully respond to GPOM. How about surgical myotomy versus GPOM? Equal technical success, clinical success was similar. However, there was more reduction in GCSI scores, more reduction in retention at 2 hours, reduced procedure time, reduced hospital length of stay with GPOM. This is another study comparing robotic surgical pyloroplasty, lower time required in GPOM, but higher reduction in GCSI score with robotic surgical pyloroplasty. So the verdict is out there. Which one's better? How safe is GPOM? Now, in the interest of time, I'm going to move forward. This is a study looking at 216 patients, 14% risk of adverse events. And what they found ultimately was no factors associated with adverse events. Experience of less than 20 GPOMs is associated with more adverse events. So, Botox injections is an option. Previously, no good data. RCTs, no difference. Some recent data showing some improvement in those with altered pyloric distensibility. Endoscopic pyloric dilation like balloon dilation for achalasia. Again, 47 patients in this study, they were considered and 53% responded initially, but at 2 years, only 32% had responded. So overall, 30 to 40% response rates. Okay, I'll just move forward with these slides. Gastric electrical stimulation not available in India is an option, but again, not great. 50% had modest improvement. So to summarize, gastroparesis has complex pathophysiology. Pyloric dysfunction can be seen in a subset of patients. Gastric emptying scintigraphy is the gold standard for diagnosis. Electrogastrography may be promising, but there's limited data. Isotope breath test and wireless motility capsules not available in India are good alternatives for diagnosis. Endoscopic pylorus-directed therapy is effective in the pylorospasm subtype, not in the others. And gastric POEM is an endoscopic preferred option with promising outcomes. Thank you.